Well, that was a really informative session, and we've got Dr. Sarah Meadows, who works with Spine West. Those of you who know Dr. Cliff Gronseth, he's been here a presenter for a number of years, and she is going to be doing a talk, or giving a talk on add life to your years and years to your life, psychiatry tip for victorious aging. For those of you who don't know me, I'm Al Manzi. I'm the publisher for The Camera and president and CEO for Prairie Mountain Media. Just a couple of reminders: masks are required unless you're eating or drinking. Keep your cell phones on silent, please. Be sure, a reminder, I'm going to remind everybody, please visit the Expo. If it weren't for all of the people in that room, these kind of programs would not be available to us. They're wonderful supporters. We will stay on schedule, and the Eats and Sweets truck should be outside soon if it's not already out there. So without further ado, I'm going to ask Dr. Sarah Meadows to start her talk. And since I don't have a proper bio for her, I'm going to ask her to just go ahead and introduce herself.
Okay. Hi, I'm Sarah Meadows. Can you hear me well enough? No. Okay, so I am, just to introduce myself, I'm Sarah Meadows. I actually grew up in Boulder. I'm a DO. I was trained at the Arizona College of Osteopathic Medicine in Glendale, Arizona, and then my residency training was at Northwestern in Chicago. I'm a physiatrist, and that's actually part of my speech. So in fact, I'll just start in that. So you say, what is a physiatrist? If you've ever heard Cliff talk, many of you kind of probably know us at Spine West. We treat sports and spine, a lot of pain and functional issues. That's kind of our business, and that's not really the reason that I'm here to talk about. But physiatry, so if you've ever heard the word physiatry, and some people get it mixed up with psychiatry, which is a totally different field, physiatry is also known as physical medicine and rehabilitation. So if you've ever met a physiatrist for treatment, you might have been to Craig Hospital for a spinal cord injury, a brain injury, a stroke, an amputation, this kind of thing. So in that jurisdiction, that's a physiatrist who is helping you to achieve function in this acute injury, and then getting you back to the best function that you can get, including lots of different things. That's an inpatient acute rehab. Physiatrists also cover people in a subacute rehab setting with more consultation of what this person might need for function, for return to home, in conjunction with a physical therapist, an occupational therapist, and a speech therapist, etc. Then there's people like Cliff Gronseth and I, John Toby at Spine West, physiatrists that work in an outpatient setting, and our major focus is on function for, just your adding years to your life, life to your years. We say things like saving lifestyles, not saving lives, get it? We're like kind of looking at what's going on with your musculoskeletal system and helping to improve your function. So that, in a nutshell, is what is a physiatrist. And I'm happy to answer any questions in the end of this speech, because a lot of people say, I've never met a physiatrist, and they go, oh no, but I've had back injections. And so oftentimes that's a physiatrist who's been managing that care to help you get to the right place. The focus of today's talk is really, Cliff gave me his mind map and said, physiatry tips for victorious aging. And so when a doctor like me looks at a person, we go, okay, well, how can we prevent loss as we're aging? And we look at sort of like from the inside out. So bones, muscles, nerves, cardiovascular endurance, neurologic balance, these kind of things. So I'm going to just go through a few of those different topics. They're pretty simple, and in fact, the concepts are just adding just like this tiny little bit of extra to our life that can really help our body in this next aging stage for wherever you are in your process. One thing that's become very clear to me in this last year and a half with the kind of COVID and less activity is that we have gradually been deconditioning, even though we we don't really know it. We know that, like, well, we stayed home, but we did our walking and we did our little exercises, but what we weren't doing is going to as many events like this, for example. So in order to get to this event, you had to go out to your car, park in the parking lot, walk all the way around, and that's all super great for your endurance, for your weight-bearing bone health, for muscle building, etc. So it's a huge topic right now. Let's say you were in the hospital for some major illness and you had to recondition. That's a journey that we take usually with a physical therapist, somebody that helps us increase our function daily, slowly, so we don't cause injury. I think in general, post-COVID or in COVID with increased activity, we're just trying to add a little bit extra every day for our bodies. When we talk about bones and what's the risk? What's the risk of our bones aging? The major risk is osteoporosis, right? So osteoporosis is bone loss because we have less, in general, just because it's happening no matter what we do. And the ways to improve it are to add some weight bearing, right? Anything weight bearing added to our bones with gravity is helpful. So we encourage people to add walking. Everybody who's walking is adding a weight bearing exercise to their life. In addition to that, you can add something like some soup cans, right? So I like to add super simple ideas to my patients' lives because otherwise it overwhelms them. What do you mean I have to do all these exercises, 60 minutes a day, etc.? You can take a soup can, you can put that in your arms, you can walk in place. These are just like added little weights over time that we encourage. If you meet us in the clinic, you'll note that we're constantly looking at your life, your lifestyle, and trying to tweak a few different things with the most non-interventional way possible, whenever possible. Soup cans and a backpack is helpful because a lot of our osteoporosis shows up in the vertebra of the bodies, like with compression fractures. So some people will put one soup can in the backpack and walk extra. They'll add 2 soup cans, etc. We're not trying to add injury, but again, these are simple little ideas. The next level of the body that has some influence with aging are the muscles. So muscles are the same, the muscles of your cells are there. They're there, the same number are there. They don't go away. They're just bigger or littler depending on what you do. We know, obviously, it's easy to see that as we age, the muscles, those muscle fibers and cells are smaller. And so we're trying to do maintenance to keep those muscles just helping us to do the things that we want to do. And then when we want to add strength to those muscles, in order to do that, you really have to lift like the heaviest weight that your body can handle in the smallest number of reps. So if you remember in the old days, people like bodybuilders, they would do like 8, 6, 4 reps to gain strength. Well, that's sometimes not very practical for this human body that's, aging and then joints hurt or different things don't feel good, but that really is the premise. So for some people, just adding a soup can is, they can do 6 reps of that in their bicep. Or somebody else, it could be 20 pounds, and age has nothing to do with it. But if you're trying to look at the science of muscles and how to gain strength, that really is it. That's not exactly what I'm not trying to say, oh, hey, everyone go out and lift weights. I'm just giving you a little bit of the science, and also any little extra thing that we can add for strength is great. One thing that we talk about for muscle strength that's very functional and practical for people moving forward into the aging life or to prevent injury and disability is, if you, everyone has to get off the toilet seat or get out of a chair. Instead of getting out of it just one time, try doing it 3 times. So that's that squat where you're having to go all the way down, all the way up, and you're firing lots of muscles, and you're doing it against gravity. So that's, for a lot of people, that's the maximum weight that they can handle, but just adding 1 or 2, or when Cliff and I were talking yesterday, he said, or what about going up the stairs a couple extra times a day? Remembering that we're not doing as much as we used to do. We're not maybe going to the Rockies game or the Denver Center for Performing Arts or these little extra things that we were doing that was making us go up the stairs, get out of our car more, walk longer distances in winter if we can. So anyway, that's another topic of conversation. The next body part that we talk about are the joints. So this is a really interesting topic in a lot of our patients who are having change in function because of a joint pain, their hip or their knee or their shoulder. So the way that a joint actually works, it's just the two bones that come together, and there's a cartilage lining, right? So the knee is an example. There's a cartilage lining that's over the two different bones, and that over time, it's kind of like your tread on your tire. You sort of only have so much tread on your tire, and over time, you'll sort of wear that down, and it's wear and tear. Cliff likes to talk about it. It's like more wisdom to the joint. That joint can only take so much. We do like to load the joint with walking. Even there's lots of data that even says running isn't necessarily a bad thing because you're vascularizing that joint. Running in our early stages, I'm not saying just go out and start running today. Those joints, eventually, when that cartilage sort of wears down, then there's little divots in the cartilage, creates a little inflammatory cascade that happens, and then that's when you might see some swelling in a knee, for example, or pain in the knee that is causing you to not be able to get up off of the chair kind of concept. This is a physiatrist gets involved in these kind of problems, back pain, knee pain, hip pain, etc., looking at muscle balancing. How can we get the body to do it? Get the body to function in a different way. For the knee, we oftentimes you go, why do we have to go to the physical therapist? We're trying to balance the hamstring tightness, the quad weakness, the calf tightness, and if we get those things pretty well balanced, it's very surprising how much better a knee can feel. So lots of you have probably been sent to physical therapy where they made you do all of these like kickbacks with your glute muscles and then quad muscle firing with maybe a bicycle or different activities that they give you for that. That's all muscle balancing. For your spine, for example, muscle balancing is your core muscles that are holding you together like a tent. So the center pole of a tent needs all of the strings to be tight, and in order to keep our spine lifting us against gravity, we need our core muscles to lift us up. So in fact, even with you sitting there right now, you can be doing an activity that is your deep breathing. So you breathe out and your belly goes out, and you breathe in and your belly button goes towards the chair. It lifts you against gravity, and now you've done one rep of an exercise, and it's easy, and it's not a 60-minute physical therapy personal trainer exercise. It's something that you can do on a daily basis when you're sitting, when you're driving, etc. Once you do that breathing exercise, you can lift one leg and tap it down, lift the other leg, tap it down, and now you've done an even extra exercise that's trying to condition your core muscles to lift you against gravity. Lots of people want to talk about what other treatments are there for these arthritic joints that we have. So the knee is an example of a joint that we look at the overall function. What can we do with anything that you have, your innate ability to kind of help the healing of that problem, or just improve the function of that problem. Then when that is not successful, we look at different things like bracing. There are people before they get to a knee replacement that they try these unloader braces. In between that, then there are all sorts of different injections that you've probably heard of, maybe have had. Does anyone want to raise their hand if they've had injections in one or many of their joints? These injections for the knee, for example, if your knee is very swollen, you come in with a really swollen knee, we will typically use a steroid to decrease the inflammation in a very swollen knee, and that will decrease the pain and the inflammation in the joint. And then we boost you, or kind of shoot you out, and try to help. That's to help boost you along to improve your own function. You go out now with less pain, and we hope that we can get those muscles firing, etc., and that you don't have to come back. There are other treatments that are, in the FDA-approved category that are called hyaluronic acid. Really, they're only approved for the knee, actually. It's a lubricant that is put into the knee in different series of shots, either a 1-shot, 3-shot, or a 5-shot series kind of concept. This is a lubricant that goes and bathes those crevasses in the cartilage to try to decrease that sort of inflammatory cascade, which causes that swelling and pain. That's probably best used in the mild to moderate arthritis category. There are many other injections that are used that aren't really in the evidence-based category as much. I'm happy to talk about those after if you guys have questions about it. It used to be called regenerative medicine. That categorization has been taken away, but that's for things like stem cells and platelet-rich plasma. That's the joints. Other things that Cliff gave me his mind map for how to think through, how he thinks through things. So it's kind of fun to be here thinking like how Cliff would think through this. The other things that I've already sort of touched on, and the next two super important categories are your cardiovascular system, right? So for your endurance, to keep you healthy, for your heart and your lungs, and how do we do that? And you can get real scientific about these things, or you can use things like Cliff said the example he uses is the Borg scale. Not too easy, not too hard. So for one person, not too easy, not too hard is literally just walking from here to the car. And that is, well, I'm walking with my mate, but yet I'm getting a little bit short of a breath, and that's kind of not too easy, not too hard, and that's something that you can do, that you will do, and you will maintain. If you go to some sort of fancy program that tells you to do all these things, but you're never going to do it, or it doesn't feel good, or it's too hard for you, then you're not going to do it. So we're always trying to find the sort of psychology of each person. What do you like to do? What will you do? What feels good? And what is going to kind of improve your function? So not too easy, not too hard, and what are you likely to do? The sort of last big category that we talk about is sort of your neurologic system, primarily as it relates to balance and falls. So if you've come to our office, if you've seen me as a patient, you'll know that we're pretty straightforward about things that we see. If we see you walking in and it's a very unbalanced gait, we're going to start talking immediately about your fall risk. And you may not like the conversation because you didn't want to be told to do, use a cane or use a walker. But so falls are like sort of our most high-risk thing that can happen to us as we're aging. The incidence or the risk for once you have a fall, I think you've probably all seen this data in different magazines, et cetera. If you have a fall and break a bone, that the ability to recover from that is very hard the older that we are. It's a pretty obvious concept. So we look at people and we go, well, how do we prevent falls? Well, we brush like we're brushing our teeth every single day to prevent some type of, dental problem. We are, in theory, supposed to be working on our balance every single day to help the crossfires from our brain through our spinal cord down to our foot. So one example is, actually Cliff said to this to me in the office. He goes, yeah, the data says that if we can stand on single leg for 30 seconds on both sides, that our fall risk decreases precipitously. So I stood up immediately and started standing on a single leg to see if and would he time me and that kind of thing. We did, at that moment I talked about, but you have to have a little stabilizing place, right? So you can have a desk or a stable chair or something that's very close. So your finger is here and you can hold on. See if you don't need to hold on. Go back to holding on. See if you don't need to hold on. This kind of thing. This is something really easy to do. Tons of data that supports it. That's all you have to do. Just stand on single leg and practice that. The other thing is, if you can't do that, you can also just shift your weight. So you're telling your brain, you're training your brain from here all the way to the floor that you're just moving in space, and my foot is still touching the ground here. like this, kind of like ballet, kind of like dance, but you're training your brain. I'm moving in space. The more motion in different planes that you can do, you're training your neurologic system. I think we all know that, but we forget because we get into our very specific life that we like to do, and it just, again, adding one or two little things. Lots of evidence for Tai Chi. So in some of the senior centers, online options, even some of the television stations, I think, have Tai Chi or chair exercises that are encouraged. Tai Chi has a lot of balance in it, even though it's not doing this really dramatic balancing on one leg that seems pretty hard for a lot of people. What else? Oh, so fall risks in your house. If you've ever had an occupational therapist come to your home, you'll know that they walk in, immediately start looking at things and start taking away things that are on the floor, like throw rugs that are movable, that aren't I guess, tacked down in place. They want different furniture moved, et cetera, for the safety of your home. And that's pretty offensive to some people, but there is a big reason why we do it. Avoiding falls. Good night lights are important. We also know that bifocals can be a risk, so everyone has to train themselves. If they are walking with bifocals, you have to be careful of that last step, careful of looking in front of you, being very cautious about how you're using your vision with those glasses. We talked about walking poles. Those are something that a stabilizing device that's not so obvious, like a walker or a cane. I encourage my patients, you guys all look pretty healthy, you're here, you made it, some people are at home on Zoom. I do have this hard conversation with patients who, have pain or disability or something that's going on where they can't walk. And outside, they don't feel safe walking outside, et cetera. So we start having that hard conversation about what if we added a walker so that you can add more function and more distance, more cardiovascular, more weight bearing for your bones, more muscle building, and then we ditch the walker when you're done, when you've improved that. So that is, always we're looking for just increase it, increase your steps, increase your function, add just a few things. That's really just to kind of wrap up my conversation, and then answering any questions that you have. The physical medicine rehab principles are that do something, add something that you're going to do to your life, add a few extra steps, go up and down the stairs if you can more, get up and down from the toilet or the chair multiple extra times a day. The best program for you is the one that you're going to do. And we say this to our patients a lot in the room. It's a 6-minute program. It's not a 60-minute program that we're adding every single day for your function, so it's not so overwhelming. It's cans of soup. It doesn't have to be some big fancy program that you're in. And from Cliff, it's like watering your garden for the flowers in the spring, right? So these are all the reasons why we do these things. So, and I'm happy to take questions.
That was great. Thanks so much, Dr. Meadows. A couple of questions, and then we'll get to the audience. You mentioned plasma-rich injections and stem cells. There's been controversy as to whether those injections actually are doing what they're designed to do. What's the newest information on that?
The newest information is there's always a request for more information. So every conference you go to, if you really dig deep into the literature, you're going to see that it says, more research is needed. So we really haven't gotten there. I'm not an expert in stem cells, and there might be someone who comes up here and says, there's all these things. One thing I know for sure is that the categorization has changed. We cannot call it regenerative medicine anymore. So that's kind of lagging maybe in some of the literature and some of the advertisement, but because it's really not regenerating the cartilage, it's kind of going in and doing what I talked about with those other treatments, like bathing with the hyaluronic acid, bathing the cartilage with, this kind of solution that we've created from your blood or your stem cells, and then decreasing the inflammation. So it's not regenerating the cartilage, it's not regrowing the cartilage, and we're not allowed to say that anymore.
Excellent. Questions from the audience?
You mentioned walking poles and then crutches and walkers, but it seems to me there's something in between. The Canadian crutches, where they seem to be walking poles where you can put more weight directly on your arms. What's your thought about that as a next step up from walking poles?
I like anything that is improving your function. So for each person, it's different, right? What they can tolerate, because the walking poles, in truth, they're supposed to be. We're using them for stability, and the tip of the pole is actually supposed to be hitting behind you, like cross-country skiing. So you're sort of using your arms in this way where the tip of the pole is hitting behind you. It's not so much straight on like this. That does have quite a lot of load on your shoulder and the sort of the tendons of the rotator cuff. So in that case, it just depends. It's like a balancing act between what's going on up here, what function are we needing, and that it does load the shoulder quite a bit. But if it gets you up, loading your body, the bones for gravity, that kind of thing for osteoporosis, lots of muscle gain, then it's a balancing act in my. It depends on the person and the injury or the function.
Thank you for your talk.
Yeah.
You mentioned the use of cortisone steroids to control inflation. I'm sorry, inflammation. Sorry about that. Yeah. I wonder if you could comment on the use of cortisone steroids in tissue degeneration and whether or not that's reversible or permanent. Could you do that?
So tissue degeneration, you said? Yeah. So steroids are a particle. Well, when we use steroids into a joint, for example, it's a particulate. There's different particulate density or weight that we use for various things. For a knee, for example, we might use like a mid-weight particle strength. This is probably a little bit overly technical, but and we in the lifetime of a healthy knee with healthy cartilage, we would avoid steroids altogether, or we would have a maximum dose of like 3 steroids in a year in a healthy knee with healthy cartilage. So in my 14-year-old football playing child, or actually they need to be older than that, like a 21-year-old football playing child who gets an inflamed knee, can't calm it down, the question is, would you really put steroids multiple times into a healthy joint? The answer is as little as possible for that specific injury and individual. When we get to an aging joint, we're no longer dealing with that thin hyaline. It's really amazing, the cartilage, the way it looks. It's like this thin, shiny, beautiful structure. When it's young and uninjured, when it's a little older, it's got all these little crevasses in it, and it's not as shiny and not as healthy looking. So the answer to your question is that, so then that's more of a compromise, because we've already got the cascade happening of that degeneration anyway, and the inflammatory cells being there in and of themselves are perpetuating that cycle. So when we use steroids, we're trying to use it judiciously in a joint, for example, in the knee, to just calm the inflammation down, and we try to boost you along and never do it again if we don't have to. But there are people who are in a cycle of getting a steroid injection 1 to 3 times a year in an unhealthy joint who have chosen not to replace the joint to keep their function going. So if I can't move my knee and I'm in a wheelchair, is it better to have a steroid injection to keep me functioning, walking, cardiovascular, bone health, muscle strength, etc.?
Let me add something to that. Will the steroid injection accelerate that tissue degeneration?
So that's the kind of the current literature that you're reading, or the kind of in the mainstream media, but it's a two-sided story, right? So you've got all those inflammatory cells. So if we just leave all those inflammatory cells, then is it better or worse to just calm it down and boost the person along? Mm-hmm.
When I'm out walking, I can comfortably walk. When I'm out walking, I can comfortably walk at about 3 miles an hour. By pushing a little, I can do 3.5. Am I hurting or helping myself?
Just whatever is not too hard and not too easy. So you just kind of watch your ability to do it, your breathing capacity. If you feel like, whoa, this is way too much. So that's, so some people get real scientific about the heart rate and your age and your male or female, your age. Should I do 120? They have all these fancy devices. And in the end, it's better just to, like, whatever you feel like is pushing yourself, but not overdoing it. It's not a great answer, but.
One more question.
Could you briefly revisit the controversy or ideas of multiple reps versus high weight?
So you mean for muscle gain? So it's maintenance versus gain. So maintenance is, you can do, just regular reps, whatever you can do. You can actually do high reps, moving the body. I mean, you can gain or you can maintain muscle just by doing arm circles or heavy hands with 1 pound weights like this. But really to gain muscle, you have to add weight enough that it's hard to do multiple reps. So it's different for every person. But, there was that early, probably, do you remember doing weights where it was like 10, 8, 6 kind of thing? So you get the amount of weight for you that is where you can only do 10, 8, and 6 reps. But there's the problem with that, I mean, especially in a body that has multiple things going on as we age, is injury in other parts of the joint. If you just isolate the bicep and you're just going like this, it's probably okay. Where if you start doing heavy weights in like a merchant press, for example, you can aggravate the rotator cuff if you don't have good muscle balancing and shoulder positioning function, etc.
Well, there's always so much interest in this, and we really appreciate all the information, Dr. Meadows, that you've given us today, and we'd like to thank you for that.
Yeah.
And let's give Dr. Meadows a round of applause.